So welcome to this online International Upper Quarter Sports Rehabilitation Congress, organized in multi-cooperation between NOVAVIA Project, Guida galattica per fisioterapisti, and LaFisioterapia.net. My name is Sebastiano Nutarelli of the NOVAVIA group, and I'm going to play the moderator role together with Paolo Perna of the Guida galattica per fisioterapisti. So we're going to host some great speakers today, top-notch upper limb clinicians and researchers, specifically speaking Joe Gibson, Ian Horsley, and Martin Asker. The Congress schedule is this one. Basically, we will proceed with all the presentations first, then we'll submit some questions that we received from you guys. And when I say you, I mean you that are watching this online. In fact, we ask you through our 3 groups official channels, what questions you would have asked yourself to these highly qualified presenters if you would have had the chance to attend their lectures in an actual Congress. So we made public our today's speakers' presentation topics, collected questions, and that's what we're gonna do. We're gonna ask them for you. And this said, I'm gonna now pass the word and the mic over to Paolo.
Thanks, Sebastiano. I'll be very brief before handing over to our first speaker. Obviously, this partnership between NOVAVIA Project, LaFisioterapia.net, and Guida galattica per fisioterapisti started on the idea of creating an event with international speakers based on 2 interests that we all share. One is physiotherapy, and the other one is sport. So we combined them together in a Congress on sport rehab. Today, in particular, we want to focus on the upper quarter. So I'm honored to be part of this project, and I hope everyone will enjoy their time listening to this amazing panel. Please feel free to share the link of the event with your colleagues and friends, and please stay in touch with us because there will be more events coming up soon, like this one. So now I'm going to introduce our first speaker, Joe Gibson. Obviously, even though she needs no introduction, I'm really pleased to introduce her. Joe Gibson is a physiotherapist, and she's a researcher in the UK. Currently, Joe is a clinical physiotherapy specialist at the Liverpool Upper Limb Unit based at the Royal Liverpool Hospital in the UK, as well as having a consultancy role with several elite sport teams. She lectures nationally and internationally about shoulder rehabilitation, and she runs her own courses all over the world. She has published in some peer-reviewed journals, and she's author of several book chapters. But now I will pass it on to Joe, who's gonna present today on the kinetic chain and sporting shoulder opportunities for rehabilitation and performance.
Hi guys, it's great to be here. Thanks so much for inviting me to be part of this. I think it's a fantastic initiative. So thanks to Paolo and Sebastiano and everybody involved from NOVAVIA, Guida galattica and LaFisioterapia.net. I'll get going with my talk if that's okay. So these are really crazy times. It's great to be here with this initiative in terms of a different way of presenting to you all. And as you heard from the guys, my job today is to talk to you about the kinetic chain and the sporting shoulder and really consider what the opportunities are potentially in terms of rehabilitation and performance. Now, for those of you who don't know me, I'm basically based in Liverpool in the UK, up the road from Ian that you're going to hear from. My normal job is either in the hospital or in private practice, as you've heard. But with everything that's going on at the moment, I kind of spend most of my time dressed like this. And if I see my sports people, then it tends to be online consultations. So very different times. In Liverpool, we're pretty stressed at the moment because of the football, because we were looking good for winning the league. And now we've got to wait and see what happens. So challenging times for everybody. And I think I spend a lot of the time feeling like this. But today, in terms of getting on to what I want to share with you, there's really 3 key areas that I think it's worth us looking at in terms of reflecting on our practice, but also looking at opportunities as to how we can potentially do things better or maybe monitor our athletes in a different way. So I'm going to look at the relevance of the kinetic chain in sporting injuries. I'm going to look at its relevance in performance, and then also just some simple things in terms of the emerging evidence as to how we can incorporate it to enhance our rehabilitation. So if we look first of all in terms of what we mean by the kinetic chain, if I'm honest, I always cringe slightly using the term, but it's something that's been widely used in the literature, and if we want to compare meaningful research, it's absolutely crucial we use that term. But really, we're just talking about normal movement. Whether I go to reach into a cupboard or whether I'm an elite athlete that actually goes to do a throwing action or to hit a ball with a racket, the bottom line is there's this fantastic intersegmental transfer of force, which is dictated by range of movement, strength, neuromuscular control that allow me to achieve my goal. So we're just talking about that interaction of the upper limb in normal movement. Now, in terms of, oh, hang on one second, sorry, let me get rid of that sound, I do apologize. So if we look at things like the baseball pitch, this is where an awful lot of the research has come from in terms of informing this concept of the kinetic chain. And anywhere between 50 and 80% of the power of the throwing action actually comes from the lower quadrant and the trunk. If we look at the aim of many sports, it's about that maximal acceleration and speed production at that terminal segment. And it doesn't take a lot to work out that this is inherently dependent on coordination at all the segments of the body. So, but it's very fair to say that the majority of the research, certainly in the early days, came from that baseball population. So we have to consider the transferability of that. Now, if we look at the role of the kinetic chain in performance, again, there's a nice evidence base that actually gives some credibility to the importance of looking at our whole athlete, not just their shoulder, if they're in perhaps an overhead sport or something where the arm is a predominant part of their sport. There's nice evidence that shows a key correlation between throwing velocity and lower limb peak power in elite handball players. I'm sure Martin can tell us much more about that later on. In terms of the sprint swim speed, again, that's been shown to correlate highly with lower limb peak power in freestyle swimmers. In terms of javelin throwing performance, strength measures and muscle mass, again, have been shown to have a high correlation with javelin throwing performance. So that performance output of the upper limb does seem to have an evidence base when associated with improvements in lower limb peak power. Interestingly, Tim Gabbert also did some work also demonstrating a high correlation with lower limb strength and power with a rugby player's tackling ability. So in terms of enhancing performance, again, if we're trying to get somebody back to sport, we can see the sense in making sure we strengthen the all-round athlete, and particularly those power measures. And increasingly, we're seeing that rate of force production and power seem to be more crucial than strength itself, so the ability to use that strength. Now, if we then have a consideration of the potential role in injury, this is where it gets interesting, and we have to be a little bit honest about the methodology. It's more of an association than a proven cause. However, we do have quite an extensive evidence base looking at the relevance of certain factors. Studies that have literally just used the one-leg stand when they've looked at people at the beginning of a season, or they've looked at a cohort with shoulder injuries compared to a cohort that haven't, do show a consistent theme that patients who fail a simple one-leg stand test or more complex balance measures do seem to have an associated higher risk of developing shoulder pain in the subsequent season. If we look at measures of lateral trunk endurance in baseball pitches and certain throwing sports, again, a weakness compared to a control cohort does again seem to make people more at risk. We have studies that show that if we do fatiguing drills on the glute muscles, so the abductors or the external rotators, and measure the impact that that has on the shoulder, that if we do a fatiguing drill on that lower quadrant, the consequence is that the shoulder has to throw faster and through a greater range of movement to actually have the same performance output. There's also studies looking at strength and range of movement measures and showing that, again, if we measure people through a season, fatigue in the lower quadrant, changes in strength seem to result in decreases in range of movement. And again, that seems to have some predictive value in terms of upper quadrant injuries. Now, obviously, it's not the whole story, but these are interesting things for us to measure. There's also no doubt that people that have had an ACL injury, an ankle injury, a trunk injury, again, seem to have an increased risk of developing shoulder pain if they do a sport where upper limb function predominates. So again, some really nice simple clues with an evidence base that allow us to be vigilant in somebody who comes to us with a shoulder injury, particularly if it's something that's progressed over time, and particularly if it sounds like they've done good shoulder rehabilitation. So in terms of other things that might make us think, there's lots of authors, again, that have looked at balance as a measure and, again, a potential risk factor in developing shoulder injury. Now, balance itself is a difficult one because I think we have to be honest that most of the studies out there actually compare people who already have pain with those that haven't. And so those simple balance tests probably are potentially misleading because a patient or an athlete won't use their normal balance mechanisms in the same way, arguably, if they have pain. However, there's been some recent studies using things like the lower extremity wide balance test, and certainly showing that athletes that had problems with that posterior medial direction again seem to have an increased risk of up to 3 to 4 times in the subsequent season. Now, the thing that really interests me, and something that we've shown in our research, but has also been shown in the tennis population, is the change in thoracic rotation as a risk sign of people that are likely to develop shoulder pain. So Martin did a lovely study where they followed athletes up through a season, and they actually measured their intersegmental rotation and found that before their tennis players developed shoulder pain, there was this gradual loss of intersegmental rotation, particularly in the thorax. My colleagues at Liverpool Hope University are doing some similar work with baseball pitchers. It still fascinates me we have enough baseball pitchers in the UK to do this research, but it would seem that they're there. But again, it seems that a change in this rotation, and specifically a reduction in thoracic rotation, again, do seem to have some predictive value. So measuring thoracic rotation and seeing if there is a change seems to be a worthwhile investment in our management. Now, biomechanics is always a very controversial subject. I was going to put a minefield up here. And there's no doubt there are, again, some associations. If we look at baseball, there's no doubt that foot position and trunk lean have been seen to be relevant. In tennis players, a lack of knee flexion at the wind-up of the serve has also been shown to be relevant. But I think what's really important when we look at biomechanics is there is no ideal. And certainly you can put up lots of pictures of patients or athletes that seem to have appalling biomechanics, but actually perform incredibly well at top level. It's more about what contributes to these things in terms of strength or range of movement deficits that appears to have more relevance. Now, the other thing to say when we look at the kinetic chain in the potential role of injuries, it's not just about looking at that bottom-up model, not just looking at the effect of the lower quadrant and the thorax on the shoulder. There's also some evidence looking at the effect of bottom down. It's well documented that strength deficits in the cervical spine, and particularly symptomatic cervical spine patients, have a higher risk of developing shoulder pain. And this is no less prevalent in our sporting populations. The other thing that's really interesting is if we look at the wrist and the forearm and the elbow, again, strength deficits in those again seem to predispose to shoulder injury. If we look at tennis elbow patients, again, if we compare them with people without symptoms who do sport, we will find a definite strength dominance in the dominant arm for their sport, whereas those who go on to develop symptoms don't seem to have this additional strength in the arm that then becomes injured. So again, we can see the importance of looking at our athlete as a whole, both in terms of the lower quadrant and the trunk, but also just looking at things like hand grip and some other measures of strength in that upper quadrant. However, I think as ever with these things, you note I use the word association a lot. There's a correlation, an association with a lot of these factors, but we continue to have to acknowledge that load too much too soon, or periods of rest followed by introduction of load too quickly, fatigue across a season and how that affects range of movement and strength, but also age and genetics. It's a sad fact that there's many factors we can't influence because they're just genetically pre-programmed. But what is interesting when we look at fatigue and we look at load and we look at the age of our athletes, all those factors that I've discussed increase the relative risk in combination with those factors. Now, in terms of the potential role in injury, the other thing I have to say at this point is not to forget the elephant in the room. The bottom line is, as well as all these different things that potentially can impact the efficiency of force transfer through that system and how somebody moves, we also have a great evidence base that shows us that an individual's pain beliefs, their fear avoidance, can also have a massive impact on the efficacy of their movement strategies. We have evidence from the apprehension literature, so patients who've had a shoulder dislocation, where there might be a very negative context associated with that original injury. Their coach says, I can't believe you got injured again, you've only just got back. And we have evidence that shows that apprehension processing moves into those emotive centres. I had a rugby player recently who'd done fantastic rehab. Every test I did on him, strength-wise, movement-wise, was great. And when we looked at the problem he was having, it was very much running into a contact situation. And the fact was, he still had a lot of apprehension and fear associated with that movement, because that was consistently where he got injured. And so actually, when we videoed him, what we saw is he was almost dumping his body away and almost fixing through his thorax to try and protect his arm. But you can imagine if he does that, he actually makes his shoulder much more vulnerable. So again, we can't get away from the fact that many of our prognostic indicators are within that psychosocial domain, and we have to understand what that pain believes that patient. We can do the best rehab on those physical aspects, but if we don't understand what's going on in their life, other things that we know impact movement, then we set ourselves up to fail. So the final thing I just want to consider is also the potential of the kinetic chain to facilitate rehabilitation. And clearly this is something I feel passionately about and figures widely in my treatment of anybody, not just athletes. But the exciting thing is we're getting more evidence to support it. When we go back to considering that the kinetic chain is really just talking about normal movement and the function of the shoulder in everyday activity as well as in sport, it's well demonstrated that our brain thinks in movement patterns, it doesn't think in individual muscles. So an approach to rehabilitation that makes exercises sensory motor rich, or if you like, lights up as much of that cortex as we can, addresses some of those inhibitory patterns we see in the motor and somatosensory cortex in people with pain, but also simply just using momentum, speed, using that proximal to distal sequencing to make it easier to get the muscle system. Again, this all makes a lot of sense and has an evidence base within the neurological literature. However, the good news in terms of our orthopedic cohort is we also have an increasing evidence base supporting the impact it has on muscle recruitment. If we initiate our exercises with a step forward, a step up, some form of weight transfer, a nice systematic review done by a colleague of mine, Ellie Richardson, which is currently in press, shows that we actually get an enhancement of those axioscapular muscles. It makes it easier to get them doing its job. Similarly, it would appear it has the potential to reduce the demand on the rotator cuff. So if I'm looking at efficient force transfer and I'm looking at making life easier for that shoulder, this seems to have a sound evidence base. Now, you remember I talked about thoracic rotation and the loss of that rotation being a predictive factor, but again, it's a common area where athletes will compensate if they're fearful about a movement. So again, we have a nice evidence base saying that if we introduce thoracic rotation to our exercises, again, it has a similar effect in terms of enhancing that scapular recruitment, but also making life easier for the shoulder. So it's great that this is where an evidence base actually helps inform our process. And you can see that with the two exercises Jack did there, the step up through range and the rotation in 90-90, we just incorporate that initiation with the kinetic chain into our initial exercise prescription, really to set those great foundations of movement. Now, the other thing is, in terms of, you remember I said about lateral trunk endurance, we don't have to make these exercises complicated, but we can incorporate everything together to make it more meaningful to that athlete-specific sport or activity. And you can see here just the simple side plank adding in that thoracic rotation, but again with lots of sensory motor input to that system. So there are lots of different ways we can facilitate it. The key thing in those initial stages is the thing that gives us best value seems to be that stepping and weight transference. So something, as you're seeing here with Jack, would very much be a progression. So guys, I've done a quick run through of the things that I think are really important in the kinetic chain and the sporting shoulder. I do think it gives us potential to enhance performance, and I'm sure we'll hear from Martin in terms of the relevance of our lower limb performance parameters. I do think also it gives us some simple, very simple things that we can assess if we have somebody with shoulder pain in front of us, particularly if there's somebody who sounds like they've done good rehab for the local system, but every time they return to their sport, the system breaks down. Their injury history and some simple performance measures of lower quadrant strength or thoracic rotation may give us some clues as to what we can do to really get that athlete back on track. And in terms of rehabilitation, for me, the kinetic chain's a no-brainer. Whether we look at it just being a distraction process, enhancing sensory motor input, or actually enhancing local recruitment and making it easier to get that muscle system at the shoulder doing its job, I think it has a lot of potential to make rehab easier for our athletes, but again, potentially make them more robust for the future. So I hope I've given you some useful tips and tricks. Hopefully we'll get an opportunity to discuss about some of the specific assessment and treatment things in the question and answer. It's been a real privilege to be involved in this, and guys, just keep safe and healthy.
Okay, Joe, thank you very much for your presentation. This is quite often it's a relevant topic quite often undertook during differential diagnosis, and also while designing and implementing our rehabilitation program, so that was helpful for sure. So our next speaker is Ian Horsley. Ian got his PhD examining the issues around shoulder and injuries in professional rugby, and has published numerous articles in peer-reviewed journals on the subject of MSK injury, musculoskeletal injuries, their management, and he contributed also to chapters in several books. So alongside this, he regularly presents nationally and internationally in congresses about management of the shoulder, in addition to delivering his shoulder course internationally. He worked as a physio for the England Rugby Union for almost 15 years, and as a member of the medical team for Great Britain at the 2012 and 2016 Olympic Games, and currently is a consultant physical therapist to England football. Ian is the lead physio and technical lead for the Northwest for the English Institute of Sport in UK, associate lecturer at the Salford University. And Ian will now present on the role of the clavicle in shoulder function. So it's your turn, Ian. Thank you.
Hi, I'm going to present my thoughts regarding the intricate function of the clavicle within the sporting shoulder and its role in optimizing athletic performance and minimizing injury around the shoulder. So the clavicle, the name comes from the Latin clavicula, which means small key. And further to that, the name clavus, okay, refers to the S shape of the bone. So if we look at the bone, it is an important bone. It's the first bone to begin to ossify in the human body, and that starts at about 5 weeks. And then this medial end here starts to ossify properly at about 18 years of age and finishes around 24 years of age. If we look at the shape of the bone, we can see here medially that the bone is sort of convex anteriorly. Okay, and as we get to the lateral side here, it's concave anteriorly. So that has a lot to do with the design and the purpose of the clavicle. Now, the presence or absence of a clavicle in mammals is quite varied. If we look here at animals that are adapted for sort of running fast or swimming fast, such as a horse or a whale, we can see that they have evolved not to have a clavicle around their shoulder joint girdles from there. And the preposition for this is that it allows for an improved function through a greater increase in range of scapular motion. And so what we've got to consider as we try and run faster and swim faster, how can we adapt for not having this modification to run faster, swim faster, and stay injury free? And that's one of the things that we'll consider on the course. And the primary role of the clavicle is to position the arm away from the trunk, and it's to provide a stable base between the arm and the axial skeleton. Okay, so this allows the ability to generate adequate power and perform the reaching and elevation tasks required in sport. And it's similar, if we think about it, to the position, the boom on a crane. And we also need to consider about the effects of the clavicle. If we have a fracture around the clavicle and the effects on the muscular attachments to the bony end and the possible displacement, and how we might mitigate these factors when we are rehabilitating them. We can consider the clavicle as a bone between two joints. At the lateral end, we've got the acromioclavicular joint, which is commonly injured in sports like football, cycling, martial arts, and snow sports. And it's more common in sort of young men who are at a higher risk of accidents. And then immediately, we have got the sternoclavicular joint. Now, I'm a massive fan and banging the drum a lot about the sternoclavicular joint, because the sternoclavicular joint is the only place on the body where the upper limb is joined to the axial skeleton. And I feel that we don't pay it enough attention when assessing the biomechanics and the function around the shoulder. If we look at the clavicle, and here we have in this top picture here, showing the clavicle from sort of front on here with its S shape. And if we look at the bottom picture, as we go into elevation and the clavicle posteriorly rotates around this longitudinal axis, what happens is we get elevation of the lateral end of the clavicle. And this is an important thing, because the next thing in line in this chain here is the acromion. And obviously the acromion is part of the scapula. So as we go into elevation and we get posterior rotation of the clavicle, we'll get elevation of the acromion. And the elevation of the acromion helps to maintain the distance between the acromion and the humeral head. So this acromial-humeral distance, or which is commonly referred to the subacromial space. But to be fair, it's not much of a space when you look in there. There's all sorts of soft tissues. We've got a bursa, we've got the coracoacromial ligament, we've got the cuff, we've got the long head of biceps that are taking up, in theory, that space. But if we can maintain the distance between those bony parts, between the acromion and the humeral head, we're less likely to cause any trauma or get what is commonly called impingement around the shoulder. And bearing in mind that a lot of the things that we do in sports take place overhead, it's a necessary thing that needs to happen. So that rotation of the clavicle is paramount. If we don't get that posterior rotation of the clavicle, then what we won't get as we go into elevation, we won't get that upward rotation. So the acromion stays in a relative downward position as we get downward rotation of the clavicle, and reduces that subacromial space, causing trauma to the tissues. Again, as we mentioned earlier, lots and lots of sports take place overhead, and it's repetitive action, generally of a high force. So every little benefit that we can get out of that kinetic chain, and Joe talked about from the ground up, and if we go from the other end, from where the kinetic chain ends at the SC joint, all that working together will optimize that shoulder function and minimize the likelihood of getting any injuries around there. So if we look here at this animation, we can just see the requirements of the clavicle as we go into elevation. We can see we get that posterior rotation, and we get that elevation around the lateral end of the clavicle here, which helps maintain that subacromial space. Again, we talk about the scapula going up into elevation, but it just doesn't work in one plane. Okay, it works in 3 dimensions. There's 3 sets of movements that are required with the scapula to help maintain the elevation of the acromion. We've got that upward rotation of the clavicle, of the scapula, which we're used to seeing, and that's when the inferior angle of the scapula moves away from the midline here. We've got external rotation of the scapula, and that's when the medial border of the scapula moves towards the chest wall. So if you think about that, so with this arm here, if we externally rotate the humerus and continue that round, that's the same way that the scapula is going to externally rotate. And then here we've got posterior tilt of the scapula from there, where the inferior angle of the scapula moves towards the trunk. All these will maintain that subacromial space to its maximum. Now, these movements are influenced by a lot of muscles, but the main muscles that are talked about around here for producing that are trapezius and serratus anterior. And if we think about the role of the upper trapezius, the upper trapezius causes a little bit of retraction of the clavicle and aids in a little bit of that upward rotation as the scapula elevates in there. The middle traps work isometrically to balance the pull of the protractors of the scapula, and create a little bit of external rotation. And the lower trapezius there helps with that posterior tilt as we go up into elevation, and acts to assist upward rotation. But possibly the most important muscle around the scapula, in my opinion, is serratus anterior. Serratus anterior is a big muscle, it's a clever muscle, and it has different parts that have different effects. So if we look what the actions that the serratus anterior has, it upwardly rotates the scapula, which is what we require to maintain that subacromial space. It posteriorly tilts, again, that helps maintain that subacromial space, and externally rotates the scapula to maintain that subacromial space. It also protracts the scapula, but generally in clinic, we tend to see that excessive protraction is a cause of impingement and helps restrict the movement of the clavicle. So what we've got to think about is how the scapula works in conjunction with the clavicle to allow that optimal movement. And if we go back to sort of anatomy and physiology 101, we've got to think about that muscles have an optimal position that they work in. And in this mid-range of motion, they've got optimal actin and myosin overlap, where we get the most effortless movement, most economical movement from there. So if the muscle is not at its correct resting length, that's going to affect the function of the shoulder. So we've got to think about, first of all, the optimization of the scapular position. Because the rotator cuff is attached to the scapula, if the scapula is not moving correctly, then as we go through our range, that's going to compromise the rotator cuff and can cause overexertion and overwork of the cuff, which could lead to some of the problems that we get around the shoulder, again, shoulder pain and or instability and impingement. And then we could then get an imbalance between the pull between deltoid, okay, and the cuff, and then start to get a little bit of humeral instability around there. But the scapula can't just move on its own. It's sat on the thoracic spine. And as Joe mentioned earlier, there's lots of studies showing how important that movement is of the thoracic spine. And this nice little study gives an example by Okamoto from there, looking at baseball pitching with 3D analysis. And in this position here, this abduction external rotation, so this maximal external rotation, the cocking position of throwing, they came that the average amount of thoracic extension required was about 18 degrees. And again, in unilateral movements, we've got to think about there was a little bit more thoracic rotation required than extension, and with a bilateral overhead movement, we need more extension than rotation. So all this together helps to place the scapula in an optimal position. And having the scapula an optimal position allows us to do these incredible sporting things, like throw a handball, okay, with great accuracy and great speed, throw a baseball repeatedly above 90 miles an hour. But we also need that stable platform so we can get that force transfer through the kinetic chain. It's no good working on our sort of our 50% that comes from the waist down in the kinetic chain, and that 30% that comes from the sort of the trunk in there. If we're losing our last 20%, which comes from around the shoulder girdle, and especially that scapular stability here. So in a little bit of the research that we looked at trying to assess power, and this was in some of our GB boxes here, we looked at doing a plyometric press up here. And what you can see, we're here with the guy on the left, he's got really, really good scapular stability. And if you look at his flight time and the height that he gets compared to the guy on the left, there's a massive amount of energy leakage. Okay, there's a little bit through the kinetic chain here, but a lot around this guy's scapula, and he's not able to transfer that force. And obviously in a sport like boxing, you need that force through there. So in summary, we can see that the clavicle acts as a crank, okay, to elevate the acromion. Okay, with its rotation is governed by optimally functioning AC and SC joints. Then the action of the AC joints enable optimal positioning of the scapula, enabling that scapula to get into an upwardly rotated position, positioning the muscles in their appropriate position so they're functionally working well. That optimal scapular position allows that force transfer. Okay, that force transfer reduces load on the local structures, and that enables our excellent athletic performance. So optimal clavicle function is necessary, okay, to reduce the likelihood of injury of the sporting shoulder. And I'm not sure many people consider it in that. Okay, and we'll talk further for NOVAVIA about that on the course. And within that, we'll show you some exercises, I think, which are useful for training these. They'll be a little bit better than these exercises that I saw on the internet. So that's all for me for today. I hope it's been useful. I hope it sort of made you consider a little bit about the role of the clavicle when we're conditioning our shoulders. Thank you.
Thanks, Ian, for your presentation on a very interesting topic, and I look forward to seeing you later on in our Q&A when I'm sure we can discuss it further.
Okay, thank you.
And now to our next speaker. I'm excited to have here today with us Martin Asker from Sweden. I strongly advise to everyone to look into the amazing work that Martin and his colleagues have published recently. Martin is a naprapath, with a particular interest in shoulder problems, especially in handball. He has over 18 years of clinical experience, and he's worked with both male and female handball elite teams across different age groups. Alongside his clinical work, he's a researcher, and he completed his PhD at the Musculoskeletal and Sports Injury Epidemiology Center at Karolinska Institute in Stockholm. Currently, Martin is a group leader of the Swedish Handball Research Group at the Sophia Emmet University, and he's a member of the medical committee of the Swedish Handball Federation. So I will hand over to Martin now. So his topic is return to sport after shoulder injuries in overhead athletes.
Thank you for having me. It's always a pleasure to listen to Joe and Ian, and hopefully you get something out of my talk as well. I will talk to you about return to sport of shoulder injuries in the overhead athletes. And as mentioned, I work basically with handball players, mainly with handball players and mainly with shoulder problems. So I'm going to address this talk. I'm going to build it a little bit on handball, but it's the same principles whether you work with a tennis player or a swimmer or baseball pitchers or any other overhead athletes. So the first thing you need to ask is, what is the worst thing you're going to do with your shoulder on a regular basis? So that's what you need to be prepared for. And if we look at handball as an example, it's this. So this is what we call the contact part of the sport, or the chaotic part, with a lot of wrestling, hitting, grabbing, some strangling sometimes. And the other part of the sport is the throwing, where really the kinetic chain that Joe did an excellent talk about comes into the picture. So if you look at throwing, depending on what type of ball you're throwing and what type of throwing motion you have, it's around 80 to 110% of your body weight. That's the traction force of your shoulder each time you do a maximum velocity throw. So it's a tremendous force that the shoulder needs to handle during a throw. And that's something that we need to prepare them for, and something that we need to test them for before we say it's okay to go back to throwing. And if we look to the return to sport continuum, there was a great consensus coming out a couple of years ago from group the Bern conference. It's a really nice paper, and regardless whether you have a bicep pathology or an instability or a rotator cuff pathology or posterior impingement, which is quite common in the handball players, again, an overuse problem, and eventually they end up with a posterior impingement problem, and then they have trouble throwing, and then they come see you. So regardless of what type of injury you have, eventually down the road, you need to come back and start throwing. So in the beginning, it pretty much looks the same, regardless what type of injury you have. In the beginning, it differs depending on if you had surgery or not, and the phases will be of different length and time. But in the end, when we come down to this point, what I will address today, eventually you have to start throwing, and you have to start building up the capacity and resilience for that force that will end up in the shoulder when you throw. And my experience is that that's something that we miss often in our overhead athletes, that we're not preparing them enough for that transition into that sport-specific throwing. And in other sports, it's the wrestling or the tackling. So if we look at handball as an example, they need a lot of shoulder strength, both power and speed. It's a very quick motion, but also some endurance, because they're going to throw a lot, but when they play defense, it's going to be a lot of wrestling and a lot of covering the ball when the opponent's throwing. And they need a great mobility, and they need strength throughout that range of motion. So that's something that we need to address. And then we have the whole kinetic chain that Joe talked about with the throwing motion and the throwing technique that we need to address. And they also have an aerobic capacity that we have to check if it's good enough. And then we have the contact and wrestling and tackling, which puts a lot of grade of bracing and stability on the shoulder. So in handball, it's pretty much everything, bits and parts of everything that we have as a shoulder demand. And the other thing, when we look at workload, we have the overall workload, but we also have what we call a shoulder-specific workload. In this case, and many other throwers, it's the number of throws you do, especially the number of high-velocity throws you're doing. In tennis, it could be the number of serves, etc. But in handball, it's the number of throws, especially the high-velocity throws. When it comes to shoulder strength testing, I want to test it in a throwing position. That's the 90-90 position that we standardize. In the beginning of the rehabilitation, that's perhaps not possible because it's too painful. But further down the road, where we want to see if they're ready to go back to throwing, that's the position I want to test them. So I do the same protocol as Cools and Johansson have described. In a seated position, 90-90 position, we test external rotation and internal rotation strength, and also do an eccentric strength with the handheld dynamometer, going from the 90 position and down to 0 position when they have their forearm pointing straight forward. And we do a abduction strength test in a standing position. We can do this as a make test when we're trying to make it mostly or mainly isometric, but I prefer to do the break test when we're going into the eccentric phase. That's often when I detect if they have a strength deficit or not. And then further down the road, we start starting a throwing program. So in the beginning, it's very easy throwing. We're going, like 15 years ago, we talked a lot about distance. They were about to throw 10 meters or 15 meters, depending on the level and what phase of the throwing program they were in. But nowadays, it's much easier to talk about intensity and how much of their maximum velocity they will throw percentage-wise. Because now it's very easy to get a speed radar gun, and it's quite cheap. It costs in Sweden at least, it costs around 40 euros or something like that, and they're reliable enough, and it's also good motivation for them to when they start throwing again. So depending on if it's an adult or a youth player, they throw between 10 to 15 in the first phase, 2 sets, and they throw 1 day and then 1 day off to evaluate, so they don't have any flare-ups. And if they're passing 1 week without any flare-ups or they're throwing pain, they can go on to the next step. Not necessarily they have to start at the first step. If it's just a minor overuse injury and we have them off for 1 or 2 weeks, they can start at level 6 or 7. In this phase, it's also I introduce more aggressive, what we call sport-specific strength training. So heavier load in the overhead position, more power training, so heavy medicine ball throws, more acceleration, deceleration training, and more advanced throwing program. And with handball, we also introduced more sport-specific practice, contact, wrestling, etc. And the criteria they have for them to be able to go into this phase is that they have to be able to perform the throwing program from level 1 to 3 without their pain. And I'm saying their pain, that's the pain that they come and see you for. So they're doing all these exercises, and sports like handball or rugby or other tough shoulder sports, they're going to have some pain or some soreness in their shoulder. That's not the issue. The issue is if they're having their pain that they come seeking for. I don't want them to have that. And I want them to be able to do a brake test with the dynamometer without their pain. And they should be able to perform all the former exercises without their pain or major discomfort in the shoulder. And then when we look at range of motion, I say full range of motion, because in some diagnosis and some injuries, it's hard to come back to full range of motion ever if they have surgery for shoulder instability for one, for an example. Then we shouldn't expect them to come back to where they were before, or compare it to normative values for handball players, or even for compare it with the other shoulder. So it's what we can expect to be a full range of motion. That's what I'm looking for. Just going to show you some exercises to give you a hint of what I'm doing. This is pretty much similar to what Joe showed. With the handball players, I have to give them a ball, otherwise they won't do it. So this is pair exercise that they're doing, throwing and catching the ball, and trying to incorporate trunk and shoulder strength and stability. The other one here is starting an exercise. What often happens when they're in the defense, when someone trying to pass them, and often just being able to get your arm out, and we just want them to get stronger and stronger in that position, and also start including using their lower limb to gain some force. This one is both an exercise and a test. So just doing Supermans, going backwards, trying to get as far as possible and be able to hold that without collapsing, pretty much what Ivan was talking about. So this is something that I address so they don't collapse in this area or in this area for that as well. And this is one of my favorite exercises. Is pretty much a side plank. The player's on the towel and just dragging around the floor. And sometimes the towel gets stuck, so you have to deal with that. Should be able to be straight here, but it's been a long day. We've been shooting the videos for a whole day, so it's starting to be a little bit sacky here. We have to address the posterior part of the shoulder because that's often where we find the weakness in the throwers. But we can't neglect the anterior part as well, and especially in a handball player or other players where we have all that wrestling and where the arms end up in positions where they're quite vulnerable in the apprehension position and someone trying to pull your arm off. So this is one of the progression exercises that I do. So we start on the bench just with the rubber band, so we can increase the tension, but you will have most of the tension when you come up here and less tension when it gets down here. And then we can build on that, where we can I can push his arm down, so we work eccentrically, and I can feel when he's starting to lose the control. Then we stop and go back. And in the beginning, with all these 3 exercises, he's using both his arm, so we get a little bit help from the healthy arm. Then we go to the bar, and we want him to go as far down as possible. Many of these players will hit the floor, so we have to put some weights under the bench or have a higher bench for that. And he's working on this eccentrically, so it's a good way to increase your strength, but also range of motion at the same time gaining some strength. And finally, we have one dumbbell, and we do the same thing here. And here, I think it's just a 3 kilo dumbbell, but we work as high as possible so they can't do it concentrically, just the eccentric phase, and I will help him up. And then we introduce a lot of medicine ball throwing, so to the side, in the floor, just overhead throws. We do this one as well with the jump throw, since we have jump throw in handball. So jumping up and then throwing the ball in midair. And here's one example of a acceleration, deceleration training that we do. So he's instructed to accelerate, and when his arm is passing his head, he should decelerate as quick as possible, going back and forward with a dumbbell. And what I'm looking for here is he should be able to have it as high weight as possible without his throwing motion will be affected. So if it's too heavy, he will just rotate his trunk and not do anything with the shoulder. So that's what I'm looking for when I'm trying to set up the right weight. And then he continue on his throwing program, going up higher and higher, and in the end, he should throw at 100%. We do 3 sets if it's a professional male players, and we also have introduced jump throws. So this is where it comes down to individual. So if it's a player that normally throws a lot, he has that position, then we have to adjust this for that player. And if it's a player, it's a wingman or a line player, doesn't throw that much, these numbers will be a bit lower. So we have to adjust that. As I said, Joe did an excellent talk on the kinetic chains. I won't go into that. Just what I do with players, I film them and I watch them, so I get a rough figure on how they throw. I'm just going to show you a picture of a young athlete. She's 12 and a half or 13 years old at this picture. And on the left is how she's throwing in the beginning. And you can see in the cocking phase here, she's quite low with the elbow. The angle here is quite low. And what we're trying to do in the end is trying to get her to throw with a tennis ball, just to get the right technique in, to get that elbow higher up. Because when the ball release, we can see the elbow drops down here and it's get a lot of tension on her shoulder. And what we're trying to do is get the elbow up here. And that's a good way to start with the tennis ball. So doing that and also addressing the lower part of it, but just want to highlight what we see in the shoulder here. And then finally, if they pass the whole throwing program, we'll have a return to play test, return to sport test. And what I do with the handball players is I do a warm-up and then I measure the strength. I do the upper limb Y balance test, a couple of push-ups just to warm up. And then they start throwing. So do 15 to 20 quite light throws. We're trying to simulate the handball worst case scenario. So we do 5 to 10 burpees, side jumps in the defense position where they have the arm up here. And then they throw again and we increase the throwing velocity. And after step 2, I measure their strength with the handheld dynamometers. And then I go on to the next step. So just increasing the throwing and also asking them for the RPE. So how tough was this step 3? How tough was it overall? And how tough was it for your shoulder specifically? And then I measure the strength again, and then we're going up to maximum throws. And when I say like 10 to 50 maximum throws, that should simulate a game. So this whole test takes around 40, 45 minutes. So it's not 15 maximum throw just like that. So to throw, go and pick up the ball, and then probably it's going to be another throw within 10 to 20 seconds. And in the end, I want them to be pain-free. With that, I mean they won't be able to have their pain. So they're going to be a bit sore in the shoulder, there's going to be tired in the shoulder, that's fine. But I don't want them to have any pain. And also I look for sudden drops in shoulder strength, and especially in external rotation shoulder strength. Normally when we do this with the healthy players, they increase their internal rotation strength by 10 to 15%. So they're getting stronger in internal rotation, and normally they decrease with 10 to 15% in external rotation strength. So that's normal. That's what I'm expecting to find. But sometimes we see someone who drops between step 3 and 4, for instance, with 40 to 50% in external rotation strength. So that's something that I need to be aware of when I come to my decision if they're ready or not. And the same thing is with the RPE. So normally they're on 5 to 6 or 7 when we ask them to do this. And if someone after step 2 or after step 3 is on an RPE of 10 in the shoulders, that says something as well. Perhaps you're not painful in your shoulder, but you're quite fatigued in your shoulder already at step 3. So some suggestions for return to sport criteria is I want them to be able to brake test without their pain throughout range of motion. So I want to test them in their throwing position and in their end position where they are. And I want it to be stronger in the non-injured side, especially if it's a dominant versus dominant shoulder. So often our handball players are injured in the dominant shoulder when it comes to overuse injuries. And I want them to be at least 20% stronger than the non-dominant shoulder. So as strong as the other shoulder is not good enough when it comes to dominant, non-dominant. That's the normal. You should be at least 20% stronger. And also look at the external internal rotation ratio. So I want them to be at least 80% of the strength of external rotation compared to internal rotation. But a point here is in the young athletes, especially in young female athletes, they have quite good ratio, what we would call good ratio 1-to-1, for instance. But many times it's because they're too weak in internal rotators. So that's something that you have to address as well. I want them, as I said, full range of motion under load without their pain. I want them to be able to fulfill the throwing program without their pain. I also looked at restored capacity of restored aerobic capacity. We often do a maximal aerobic speed, a mass test, 5-minute run, and have some normative values of that. I want them to be able to do the throwing test, as I did, and I do that 3 times a week. So I do it 1 time and then 1 rest day to evaluate, and then again 1 day, and then rest, and then 1 day. So 1 time could be just luck, but I wanted to prepare for worst case scenario. And handball, it's when you're going to a tournament or when your coaches have watched some fancy YouTube clips and come back and say, I have no idea what we're going to do tomorrow. And I want them to be super confident of playing match. And return to sport, it's not just decided on one test at one point. It's based on test battery and clinical reasoning. And I wanted to perform it several times. And then you do an adequate assessment of the return to sport, or the risk of return to sport. I will take much more risk with a player that's playing their final game and it's the Champions League final than I would do with a 16-year-old talent, for sure, when it comes to all these things that I find. So I would, in a professional older players who are playing the final game, I'm fine if they're going into fatigue with the shoulder, if it's quite pain-free. But with the talent, I probably would keep them more in the gym to build up their resilience more, because they have the whole career in front of them. So that was a short summary of the final phases in rehabilitation, return to sport, and overhead athletes, and focusing on a handball player, but hopefully you get some bits out of it and you can transform it into your overhead sport, to say. So thank you for having me, thank you for listening.
Thank you, Martin, for your presentation. So definitely a topic, return to sport and testing in relation to the return to sport, way more diffuse in the literature for lower limbs. So in the most recent years, we have seen publications on it, also thanks to you and what you do in your research. So in the future will be much more probably. So as we mentioned, we collected questions from all of you guys, and this has been done thanks to the fact that we spreaded the topics, so people knew the topics of this today's online congress already. So we have some questions from people from different countries, actually, in different languages. So we're going to translate them real time for you. Some questions are individual from each of you, and then in the end, probably a round of group questions. I'm going to kick this off with a question from Italy, from Giacomo to Joe. So the topic is, in case we have what we can suspect is not just a weak shoulder, but an inhibited rotator cuff, so there is an inhibition, what's the role of neuromuscular electrical or electrical stimulation? Do you use it? What do you advise in relation to this?
That's a very good question that I might have to think about. That covers so many things. I think so there's some research by Stackhouse et al. That replicated that had been done in the lower quadrant, that showed that people who'd been injured or immobilized for any length of time, they looked at quad strength, and then they put a muscle stim on and they remeasured quad strength, and there was a significant improvement of like 25% after the muscle stim, which was thought to correlate with a lack of voluntary activation. And I think the word inhibition still causes a lot of excitement in physiotherapy because there's kind of such a variation in how people move in pain. But if you've had somebody with a period of disuse, or somebody that has lots of proprioceptive deficits, I do think there's an evidence base that if you give some peripheral stimulus, whether that be tactile, verbal, whatever, that it does have an impact on that voluntary activation. And I do think there's an evidence base for that. So in terms of the muscle stim, I would be most likely to use that in people that had maybe rotator cuff surgery, where they've had weakness for a long period beforehand. But I have definitely used it in people with nerve injuries. And I have also used it in people that have really struggled to just improve their cuff function. And my rationale is absolutely to use it as a sensory input, if you like, as opposed to specifically recruiting the muscle to improve. And we do see improvements in strength immediately afterwards. So I think, if I'm just trying to think back to the question, in terms of when we should use it, I use it in the case of true weakness, in the case of a nerve injury, but also in maybe complex patients where, for whatever reason, they're struggling to get the rotator cuff working. But that's all on a basis of the things that I talked about in the talk in terms of psychosocial and fear. But I do think there is an evidence base for it in improving that voluntary activation.
Good.
Perfect.
You, Paolo.
Thanks. Yeah, next question. That's to Ian, again from Italy, Laura. She's asking about practical advice in the management of localized AC joint pain. She actually makes an example for you, so of a rugby player. So often the rugby players feel pain in the AC joint, even though like structurally there's no damage. So in that case, how do you treat those athletes?
Okay, so as I said, I'm a little bit biased because I'm a massive fan of the sternoclavicular joint, and as I see, you can't really separate the AC joint from the SC joint. So first of all, you need to make sure you've got an optimally functioning SC joint. So we need to look at the articulation there, but also the myofascial components with that. But if we go to specifically to the question, again, it's not unusual, certainly in rugby, if somebody has got something with an AC joint, and we're looking at something probably a grade 3 really, where they start to get a lot of bother that's not settling down, that there could be some associated problems. So it's not uncommon to have a superior labral tear in there that could be creating the problem, or a little bit of glenohumeral or scapulothoracic instability that just keeps sort of gnawing away on that joint, really.
Thanks.
Okay, next question for Martin. In relation to return to sport, return to play, let's call it as we prefer. Jorge from Spain actually is asking, how well or how bad are we as a physios prepared to taking into account psychological, psychosocial, psychological factors? And what are the main factors to be considered under this domain in terms of returning to sport?
I'm glad Martin got that one.
The scale, no, I don't know how bad or how good. I can only speak for myself, and I think I could be a lot better. What I do know is, working with these athletes for over 20 years, is that you as a physio or from the medical team is often the one who got the truth. They don't tell the coaches when they're afraid of going onto the pitch, or but they tell you, or you see, as Joe described, I think, that you can tell them in certain situation that they don't do it as they normally would. So I think that we could be a lot better. What I do is just, I ask them, how confident are you to play? I know there's a lot of validated questionnaires that you can use, and that it's probably much more better than just ask them, but that's how I do it. Are you 100% sure that you want to play this game? And often you can tell by the eyes and if they're lying or not. And otherwise you can tell on the court or on the pitch that they are lying. So what I think we could be much better at is addressing this, that this is something that's really needed to look at when it comes to return to sport criteria. And it's not just us, but discussing it with the coaches and the players, and highlighting it and making it as important as strength test, or looking at throwing mechanics or other stuff as well. So it becomes much more easier for the athletes to tell them how they actually feel. I think looking at myself and two others that I know, we could do much better.
Good, thanks. So we can start with the second round of questions. So we go back to Joe. So this question again from Italy, from Stefano. So first thing is, so about the relationship between scapular dyskinesia and pain. Sometimes even if the pain is gone, then on the assessment, the scapular dyskinesia is still present. So based on this, the question is, in sport, is it important to treat the scapular movements to prevent injuries? And especially if we find that there is a dyskinesia during the preseason testing?
Yes.
Oh, I think I might have to go now. So there is so much controversy about the scapula. You can find that, we had a couple of papers that showed that scapular dyskinesis, just measured on a yes-no scale, did seem to have some predictive value. But then when the study was repeated, it didn't seem to be as convincing. I think one of the key issues is our clinical measures are not great, and they don't have fantastic intertester reliability. The ones that do are static measures that have no relationship to how somebody moves. If you put EMG on, or you use fancy stuff that you can use in a lab, it does seem to show changes in heterogeneity of how the muscles compensate with people with pain, and the same with movement patterns. So I think if you tease the evidence out, what seems to be more significant is change rather than it as a standalone measure. And I kind of go back to what I said in my talk, is that it's one potential associated factor, but we also know that we can do interventions that get rid of people's pain and they still have asymmetry. And in sport particularly, we know that if we follow people up over a long period of time, they can develop asymmetry, and that seems to be a normal finding according to their sport and other movements. The problem is we don't know at what point that becomes pathological. Now, I would be lying if I didn't say it's something I consider in my assessment, but I guess I always look at the shoulder as a whole. And like Martin and Ian have both alluded to, I think we have a good evidence base in terms of where the strength deficits tend to be and what we need to target. But for me, it's targeting those things together rather than in isolation, unless there's a particular reason or injury that would dictate a particular muscle was weak. So I think we have to be really honest, is that the evidence base for scapular dyskinesis as a predictive factor in injury is not terribly strong on good methodological trials, but there is definitely an association, and more of association if it worsens. In terms of changing it and that equating to pain, again, I don't think we have an evidence base that reliably says that, but I know that I potentially change it as part of my intervention. So I think it's one very small part, with perhaps not as much of an evidence base as other things that we can measure. Has that answered that? Sorry, I'm just like, oh, scapular dyskinesis and pain.
It's where the discussion starts usually. And
yeah, absolutely.
There would be more as well.
So to Ian now, and it's very linked to your answer to the previous question, because Luca from Italy is asking, how often are the sternoclavicular problems an issue? We know it's such a strong joint, but in a scale, I mean, ranking them, what are the most frequent ones and that you encountered in your experience? And
I think as a frank injury, it's less common, certainly less common than an AC joint injury. But I think one of the things is that if you start to evaluate and assess the sternoclavicular joint, you'll see that in a majority of people, even people who are particularly asymptomatic, that there is a lack of movement in that joint. And if you can optimize that movement in the joint, you'll get a change in their quality of movement. So it's that the more you look for, the more you find. But it's certainly not an area that I found, speaking to people across Europe, that people routinely examine in much detail at all. It doesn't have to be a massively detailed examination, but just understanding, especially as I alluded to, about the posterior rotation of the clavicle. And if you've got a stiff or hypermobile a sternoclavicular joint, that's going to compromise that clavicle posterior rotation, that then's going to implicate on the AC joint and then onto the scapula and further on there. So I think if you look for it, you might find an easy way just to compare movements and feel between left and right and symptomatic and asymptomatic.
okay.
Good. So for the last question of the round, we go back to dyskinesis. Seems like our colleagues are very much interested on this topic today. So we have that question for Martin, obviously. We have a symptomatic dyskinesis. What are the strategies to reduce pain without affecting the throwing technique in overhead athletes?
I think it builds a little bit on what Joe said. We don't know actually if we can change that or if that should be the objective to get it move as perfectly as it should, especially in an overhead athlete. I mean, in our youth handball population, in the male players, 75% of them have scapular dyskinesia, and quite a lot. So that's normal for them, and especially those with a BMI under 20. Pretty much everyone has scapular kinesia because they're skin and bone. So trying to change that, I think more of a what's the highest risk factor for getting pain or continuing having pain is you doing a lot of shoulder load, throwing, for instance. So it's more, for me, it's more like building up the whole system, the shoulder girdle, the kinetic chain, the trunk, the power, etc. And then we can start looking at perhaps throwing technique, especially in the young player, if we can change it. If it's an older player, it's quite hard to change and it's not necessarily going to do any better, perhaps worse. And they certainly don't have enough time to put like 6 months into technique throwing and gamble. So in that case, I don't address it like this is something we have to change. I want it to look like this because there's so many varieties in there. I'm more looking at pain as an outcome. And I want to see that they're throwing harder and getting stronger and more resilient. And if it still is a scapular dyskinesia after that and they're pain-free, I'm happy with that.
Perfect, thanks.
Yeah. I don't know if that was an answer, but or the answer. I used to be a scapular dyskinesist. So if you had asked me 15 years ago, I would have worked my ass off to get that scapular dyskinesia to move perfectly. And God knows I tried. But now I try less. as an outcome. Yeah.
Okay, so let's move on to questions for all of you guys. Again, from Italy, Elena. So big topics today. This is about prevention. So in-season and off-season prevention. So we know we can plan probably a little bit better off-season, but anyway, how do you guys, let's say, implement prevention off-season, but especially in-season, when you realize something is happening and you have to, you know, act, but you are in full season, and so you still have months to play ahead of you. Let's go with Joe first.
I'm probably the least good person to answer this because I'm not working consistently with teams, so it might be better if the boys answer this first, I think.
Ian, up to you.
Yeah, I mean, you know, Martin and I are quite lucky that we spend a large amount of time around our teams on a daily basis. And so we have, with our athletes, certainly in the Institute, we have daily monitoring of certain aspects of their physical performance, which may relate to previous injuries or global common injuries in the sport. And before training, our athletes will go through these self-monitoring assessments, and they've got, we sort of rate them red, amber, and green. Obviously, red, they need to do something about it. Amber, again, need to do something about it. Green, it falls within normal ranges. So we encourage our athletes to monitor themselves and then bring any changes to us, and then we can have an intervention before something does become pathological and start to impinge on their training or their ability to play. So it's very much trying to be athlete focused for them to look after themselves, which makes it a lot easier rather than waiting for somebody to get injured and then trying to work a rehabilitation plan around a full training schedule.
Martin, you want to say yours on this?
It's pretty much the same as Jens said, like trying to get them to be a little bit more shoulder smart. So trying to educate them that this is what normally comes with the sport, but when you cross this line, it's now we're calling an overuse problem or an undertrained problem, something like that. So we really need them to, we want them to talk to us when they're crossing a certain pattern, when it starts to feel this much, not when you can't throw anymore, because then we go into rehabilitation. So if they come seeing us with the beginning of a shoulder problem, it perhaps just 1 or 2 or a couple of days of load management, and then they're back on track again. Or perhaps we find something that we can work on with side on in addition to the normal handball practice or tennis practice or whatever it is. But I think that's the key thing. We have the main thing why they get injured is because they're doing their stupid sport. So they're playing handball, that's why they get injured. So if we want to reduce it, stop playing handball, and we will prevent everything, and we get Nobel Prize and all that. But so everyone should do something in terms of prevention. And then we can identify people that need an extra dosage, that perhaps are weaker or have what we would call a non-normal biomechanical throw that puts an extra stress on the shoulder, etc. But we need to get them aware of this is normal for the sport. It hurts. You get a sore shoulder because someone trying to kill you on a daily basis. But this is not normal. So now you have to address us, and we can fix it on an early base. If you can accomplish that, I think you can do a lot more. That will have a huge effect on the team.
Good. We'll go then to the next question for all of you. I'm guessing this question is based on all the recent literature that is questioning the use of orthopedic tests in the shoulder assessment. So the Alberto from Italy is asking, do you still advise to use special clinical tests in shoulder assessment? And also if you think that is still a valid tool in association to assessment of pain and function. So Joe, if you want to start.
There's some very good questions here. And particularly there's just been an editorial published saying that we should just put them out to pasture and forget about them completely. I think certainly if somebody doesn't have a history of trauma, or injury, then there's absolutely no doubt that the inter and intra-rater reliability of most orthopedic special tests, if we talk about things like Hawkins and Kennedy and NEAR and some of our rotator cuff tests, then there's absolutely no doubt they just tell us something hurts, they don't tell us why. I think if somebody's had trauma, again, if you look at our history, so our subjective examination, we know is kind of 70 to 80% of our decision making. So anything we do in terms of our clinical examination is always informed, and our clinical reasoning makes sense of anything objective, and the massive biases within that subjective. So for me, I certainly don't use, excuse me, Hawkins, Kennedy, NEAR, anything like that, because if somebody lifts their arm up and it hurts through range, it hurts through range, and it's going to hurt when I do those things. So what's the point? I'm more interested in things that are going to influence my treatment. So I do use symptom modification, and I kind of use that. So say I had somebody that I suspected they had a cuff tear because they'd fallen over and had immediate pain and couldn't lift their arm up. That's all pretty convincing. I might still use a resisted test if that's a special test. But if it was weak and painful, I know it doesn't tell me whether or not they've got a cuff tear, but I can use symptom modification principles, if you like, to kind of search out the likelihood. But as ever, my subjective is the most important thing. So I think I'd probably put more store on things that aren't special tests, but I'd be fibbing if I didn't say that I use them in the presence of trauma. And things like apprehension tests in people like with instability, again, if they've had trauma, but sometimes even if they haven't, they can be a useful measure of improvement. But I absolutely acknowledge that the inter-test reliability is moderate at best, and they don't tell us the structure. They just kind of, if they're pain provocation tests, they tell us what we already know is that it hurts. But I would never say never, if I had a history of trauma. So I kind of acknowledge the limitations and use lots of other things other than special tests to inform my treatment.
Okay, thanks. Ian?
Yeah, pretty much. I agree with Joe that in certain situations, I think some of the orthopedic tests are useful and just help sort of clarify in my mind structural things, be able to differentiate, let's say, between subacromial and AC joint and things like that will help. And the thing that always makes me laugh is how they're classed as special tests. I don't know what's special about them. They're just tests, and everybody gets really obsessed with these special tests. As Joe says, they're mainly pain provocative tests around there. If we can understand a little bit more about the biomechanics of what's happening in the test, then maybe that might give us a little bit more insight. But the ability to do a test and specifically say this is the problem, I think that's a little bit far-fetched.
Thanks, Ian. Martin?
I'll agree. What Joe and Ian said. With the traumatic, if you have an acute traumatic, not too acute because then everything would hurt, but a couple of days down the road could tell you something based on the history, and you get some confirmation and add something to your clinical reasoning. But it's in the end, it's as Ian and Joe said, it doesn't give you that much unless it's something that you probably already think of when you're taking the history. So what I sometimes use them for is if you take the Kennedy Hawkins test, just to look at how sore or sensitive your shoulder is today, and then we test it next day, and now you can do much more internal rotation, just showing the patient that it's you progressive, you're getting better, because many of the patients come back and say, my shoulder still hurts, and then they say, yeah, it's when I'm not, yeah, it's still now it still hurts, nothing is better. And 1 week before they couldn't lift their arms, just giving some objective to show them that it's actually getting better, but otherwise no.
Thanks.
Okay, thank you. So another group question coming from Julia from Italy. So lately with Ian, we happened to talk about a term they used in the past that is not evidence-based practice, but evidence-informed practice. So in relation to this, that is something that I happen to like. So the question is, what kind of associations, organizations, groups, you guys advise everybody to follow to make sure that you are linked with, or anyway, you know, to stay informed and for shoulder related problems? And whether it is evidence-informed practice, evidence-based practice, it doesn't matter, but to grow in a right direction. Joe, both national and international, obviously.
So in terms of organizations, it's worth people following to further their knowledge, or? Yeah, well, I think with Ian and I on the panel, USA would have to be right up there. I think we'll get shot if we don't mention that.
Yeah, that's a tricky question, I know. But
yeah, but there's just amazing people involved in that. If you're a member, you get access to all sorts of resources, research summaries, highlighting good articles and stuff. And certainly, if you follow the members of that, then I think that can be very useful as well. We've got the British Elbow and Shoulder Society, probably not so physiocentric, but Angie Jaggi, who's also very involved with USO, is doing a great job with her educational team and other people involved, Ian again, in terms of trying to improve that. So certainly USO would definitely be up there, because it's absolutely, that's its aim and what it's trying to do. So that probably would be my first thought. I'm sure I can think of lots more. Ian, Martin?
Yeah, no, I think, you know, to go with, you know, sort of European-wide use is probably the easiest, and certainly from an upper limb point of view, and with a sort of a big push from the rehab side of it, I think that is probably the one I'd choose the most.
Martin.
Yeah, I agree. You should follow Joe and Ian. It's a good follow on Twitter. And also there's a lot of good stuff, I think, and free webinars, etc., coming up from JOSP journal, which both good evidence-based, but also webinars such as this, free webinars with experts, upper limb and lower limbs, back pain, etc. So I think that's a really good start. I probably can come up with a lot of more, but I think that's a good start.
I think, as Martin says, I think social media, that's where it gets so much bad press at the moment. But for me, it's an absolute game changer in terms of quick, easy access to what's happening and good articles. Because if you follow people that maybe have opposing interests, that are researchers and clinicians, you can get a real kind of idea of the dilemmas and discussions. But also people seem to be very good now at actually posting good articles that immediately kind of either challenge what we're doing or give us some evidence base for it. So I'd agree with Martin. I think social media is definitely a good point, and there's a lot of free content out there now, which is really good quality.
First of all, there's been a pleasant experience. We hope that you enjoyed, and we thank you obviously for all the great presenters, and we thank you guys for accepting our invitation. So Joe, Ian, Martin, thank you very much. We hope that people enjoyed this, and you too.
Thank you.
And so on behalf of NOVAVIA Project and Guida Galattica per Fisioterapisti and LaFisioterapia.net, we thank you all for watching this first edition of the online International Upper Limb Sports Rehabilitation Congress. And thank you to you, Paolo, for to close this off.
Yeah, thanks again to our speakers for the amazing presentations, and thanks everyone for being here with us today, and we will see you soon with more events. Goodbye.